Wherever you are in the world. And we are on to the Uro-Oncology Certification course, part 2. And today we will be starting off the 4 weeks of operative surgery or operative urology related to bladder cancer. And this will be followed by next Saturday on urothelial cancer, the upper tract urothelial cancer. And then subsequently, we will be taking up the muscle invasive bladder cancer with cystectomy, robotic and open, the divergence for the next following 2 weeks. So today we will be discussing about TURBT, which essentially is the most important step in the management of bladder cancer. If you do this properly, you will be making all the right decision in the management of the patient with bladder cancer. And if this step goes wrong, then you will always regret. So we are very fortunate to have Dr. Pankaj Maheshwari. Doesn't require any introduction, a very dedicated academician, a very good friend. And he will be talking about TURBT, both the conventional type and also the arm block resection. So I'll unshare my slides and I'll request Dr. Maheshwari to please share his slides. Pankaj, the stage is yours.
Good evening. I hope my slides are visible and I'm audible. So am I visible and audible, Dr. Hammad? You are muted, sir.
Yes, the slides are visible. If you go on to the presentation mode, we'll probably be seeing the whole screen for your slides.
Is that better?
Perfect. Thank you very much.
Perfect, sir.
Yes.
So, Professor Hammad, sir, first and foremost, sincere thanks for giving me this topic. Friends, like all of you, even I had joined this program more to learn from Dr. Hammad, and I was pleasantly surprised when he asked me to speak on this topic. I really registered as a student for your program, sir. Anyway, en bloc resection has been my passion for a long time, and NMIBC itself is one topic which I really love to treat in day-to-day practice. Now, as Sir just said, that TURP is probably the most important than the basic step in management of bladder tumor. And this journey of TURBT got established nearly 6 decades back. Why is it important? Because it helps us in all 3 steps of our treatment. We can diagnose the mass in the bladder, what exactly it is. If it's a superficial or NMIBC tumor, then once we remove it, it is nearly therapeutic. Once we have the histopathological details, it also helps us prognosticate and decide the further line of treatment. So our aim undoubtedly would be to remove all visible tumors, provide a good quality tissue for histopathology, which would give us the subtype and the grade of the disease, and to know whether the tumor is an NMIBC or a muscle invasive tumor. The history of TURBT dates back to the history of cystoscopy, and when the first attempt at cystoscopy that was done by Italian surgeon Bozzini, the real change happened exactly a century back in 1926 when Stern McCarthy first described the first device to a resectoscope. Resectoscope obviously was used for prostate, and then it started being used for bladder tumors. Bowie gave us better cautery. Nesbitt improved our resectoscope. Hopkins and then Boyle and Smith saw to it that we see better during our endoscopy procedures. Just for the heck of it, I showed these 2 images. The first is a Bozzini's scope, where if you can see there are spaces for candle light. The vision obviously must have been poor because whatever they saw through reflecting mirrors and with candlelight. And the image on the left side is the Stern resectoscope. If you see, the design has not much changed, though it has become more, say, usable and user friendly for us, but the overall design has remained standard. For a procedure which has been with us for nearly 6 decades, I would not go into the details of how TURBT is done. We go endoscopically through the urethra, reach the tumor, piecemeal resect the tumor. The aim is that the tumor, a large tumor which is visible, is completely removed. And at the end of the resection, we have a good raw area where muscle is seen all around and there is no bleeding from the tumor site. We will go into the small aspects of the technique, which are commonly discussed, commonly asked in exams, and are really important in our day-to-day practice. What anesthesia is one question which would always come, and there are various different thoughts about form of anesthesia. Some people feel that spinal anesthesia would paralyze, would reduce the reflux. General anesthesia with muscle relaxation may help, but remember, both the obturator nerve reflux that happens is a direct electrical stimulation to the obturator nerve. So unless you do a obturator nerve block, no form of anesthesia is a full proof for not having obturator reflux. Obviously, a good positioning which avoids any form of injury would be very, very important. Bimanual examination was a very important part of TURBT. What would happen is the first step would be to put your 2 fingers per rectum, abdomen and the suprapubic area, and try to feel the mass and move the mass around. If you could feel the mass or move the mass, it indirectly meant that it was not stuck to the surrounding structures or probably not muscle invasive. And you were supposed to repeat this at the end of resection to confirm that one tumor is completely out. And if you still felt that mass, probably indirectly you said that this was a muscle invasive tumor. But in today's time, with better or advanced imaging that we have, this is more of a historic importance and really not something which we would do in our day-to-day practice or would add anything to the patient care. What form of electrocautery you use, there is really not much to choose. Both electrocautery would have good results, though there are some reports which say that with bipolar, the risk of complications, especially bladder perforation due to obturator reflux, are low. The bleeding is less and hence the shorter hospitalization. But again, there are multiple comparative studies which have shown both to be equally good. Intraoperative precautions would be most important. So I need to visualize the bladder well. So a good telescope with good lighting, probably with enhanced endoscopy, will help me visualize the bladder well. I must have a continuous flow irrigation. There should be a proper outflow through my resectoscope. I don't want the bladder to get over distended. A over distended bladder would cause the thinning of the bladder muscles and my risk of perforation would increase. Further, a over-distended bladder, the lateral wall will tend to go near the obturator nerve and the risk of reflux would increase. So all I need is enough distension so that the detrusor folds are eliminated and I am able to visualize the urothelium properly. Resect with a cutting loop piecemeal, debulk the tumor first, get the tumor out, and then go and resect the base of the tumor so that we can send both the tumor and the tumor base separately. Always take a deep margin, that is a tumor-based biopsy, and that should be sent separately. In the end, a good hemostasis is very, very important. I have seen people use a roller ball at the end of the procedure and especially coagulate at the edges of your resection because that is the site from where bleeding is highly likely. Should we be doing random biopsies? Now, this is a very important question. Remember that if it's a high-grade tumor and or a aggressive looking tumor, it is important to do random biopsies because even if this comes as non-muscle invasive, if random biopsies show me CIS, I am probably more would be tempted to suggest the patient to undergo a upfront radical cystectomy. If it's a small tumor with a positive cytology, I definitely need random biopsies to rule out CIS. At the end of the procedure, if the tumor looks non-invasive, looks low grade, this is a patient where I would always give mitomycin at the end of procedure. It is known that giving mitomycin reduces the risk of recurrence by nearly 20% at the end of 2 years. Antibiotic protocol. A lot of people tend to give excessive antibiotics at the end of TURBT, and prolonged antibiotics are given. As per AUA guidelines, just antibiotic prophylaxis is needed. If the pre-op culture was negative, then prolonged post-procedure antibiotics are not needed. What catheter would I use? Usually, I would want a catheter which drains well. I don't want a post-op clot blockage of the catheter. So, 20 or 22 French catheter with irrigation for some time. And once I document that the blood pressures are settled, there is no bleeding, then I stop the irrigation and then start the patient, mobilizing the patients. There would be some special situations. What do I do when the tumor is on the lateral wall? The risk of lateral wall is the obturator nerve would come very near when the bladder is overfull. The lateral wall tends to nearly touch the obturator nerve, and hence there is chance of reflux and bladder perforation will be high. To prevent this, avoid overfilling, have a low cutting current. Again, give intermittent spurts of the cut. Do not aggressively do the resection. Bipolar may be marginally better than monopolar. Lasers definitely do not have any obturator nerve reflux. And the foolproof or nearly foolproof will be to give a obturator nerve block. Anterior wall or dome, you would be working, normally we work at the floor. Here we'll be working away from what we are normally used to. So you would need to rotate your telescope, keeping the camera straight so that now you look at the roof. And then one hand on the suprapubic area, which compresses and brings the tumor towards you while you are resecting. Remember, the problem with anterior wall is whenever the bladder gets overfilled, the tumor will move away from you. When the bladder empties, the tumor comes very near you. So maintaining the bladder optimally full continuously would be very important. What do you do when the tumor is near the orifice? It is important that we do not do excessive coagulation near the orifice, because excessive coagulation could lead to ureteric obstruction. But if there is a tumor which is around the orifice, resecting the orifice with a pure cut does not carry much risk. Most often, when you cut with a pure cut, the risk of ureteric stricture, the stenosis of the ureteric orifice would be very low. Try, unless necessary, don't place a stent, because if you place a stent, there is a marginal increase in the risk of metachronous upper tract UTUC. Large median lobe is something which has fooled me twice. Two patients I distinctly remember where I suspected tumor because of repeated episodes of hematuria, and on my cystoscopy I could never find a tumor. This tumor was hiding behind the median lobe, and finally thinking that probably the prostate was the source of bleeding, we did resected the tumor and resected the median lobe, and then found the tumor there. So if this is a very large median lobe, flexible cystoscopy would help. These days we do not have 70-degree telescopes, but that would help. Otherwise, if this is coming in your way of resection, then first resecting the median lobe and then doing the bladder tumor would be very important. You could have tumors in the diverticulum. Remember, diverticulum does not have a muscle base. So it is just the mucosa, and beyond that is the extravesical tissue. So any aggressive resection could lead to diverticular perforation and the disease. And this perforation would lead to, say, upgrading of the disease, because there could be tumor cell implantation outside the bladder. So be very cautious in diverticular resections. Again, many times the angles of resection in the diverticulum may be difficult. So if it's a superficial tumor, you could just coagulate the tumor, take a bunch biopsy. If it's an aggressive tumor, then probably some form of partial or radical cystectomy would be the way to go. What is against TURBT? Any malignancy you see, say if I have a patient with a lower polar mass, I don't break that lower polar mass into multiple pieces and then remove it. I try to remove the mass intact with probably a rim of surrounding normal tissue. So that's the main oncological principle. And in TURBT, I am blatantly disobeying this oncological principle, because I am breaking the tumor into multiple pieces. When I break the tumor into multiple pieces, there is a possibility of tumor seeding, and that is one thing which is the major drawback of TURBT. Further, we know that the blood supply to the tumor, there is usually one or two blood vessels in the stalk. And as the tumor goes peripherally, the blood vessels tend to, say, bifurcate. So if I start resecting from periphery and come to the stalk, I would get these blood vessels at multiple places, and I would need to do multiple places hemostasis. But if I work on the stalk, I would have 1 or 2 major blood vessels whom once I coagulate, the bleeding is controlled well. As I have already said, once I break the tumor, the risk of cell implantation is high, especially both at the normal mucosa and at the denuded mucosal site, and hence the risk of recurrence is high. Recurrence could be because of other causes, we would come to that, but cell implantation could be one important reason for recurrence. And as we have already said, the risk of reflux is high. Detrusor muscle, finding detrusor muscle in the specimen is a criteria for a well done TURBT. Surprisingly, in nearly half of the patients after TURBT, especially done by a novice, detrusor muscle would not be found. So these are the problems of TURBT. The question is, can en-bloc excision take care of these problems? As we were saying, what are the causes of recurrence, undetected cancer? So for that, I would use enhanced endoscopy. Residual disease, I could do a second look TURBT or en-bloc resection. Drop metastasis, so especially if there is a large tumor, multiple tumor near the ureteric orifice, then always get a CT urogram done to rule out upper tract malignancies. Because most often it's a field change, we would definitely give maintenance mitomycin or BCG after the tumor in selected patients. And to prevent reimplantation, a single dose mitomycin or en-bloc resection probably would help. So is this a game changer? This treatment was first proposed somewhere in 1980. The first real report came in around 2000, where they said that for a tumor smaller than 2 centimeters, just mark the tumor 3 millimeters around this tumor, and then with a Collins knife, try to go under the tumor. So you are removing the tumor intact with a layer of detrusor muscle with it. So this is how the journey of en-bloc resection started. What are the advantage? I remove the tumor intact, hence there is probably no cell implantation. The possibility of getting detrusor muscle is much higher. And when I do it with laser, the risk of bleeding reduces. I can do it in patients with antiplatelet agents. With laser, there is absolutely no obturator reflux there, and hence much reduced risk of perforation. What are the steps? The first step would be to mark the incision. So there I can see the ureteric orifice. That's a tumor. I, with laser around 3 to 5 millimeters away, I would make multiple laser spurts and mark around this tumor. So that becomes now my resection line. I've initially started at low frequency, but once I have got a feel of it, I increase the frequency and now I start undermining the tumor. If there is a difficulty, I go from say 6 o'clock towards 12 o'clock. So I'm going anteriorly towards the anterior wall, remove the all the attachments, and at the end you should see the detrusor muscle all over in the tumor. And such floating tumor, it is very easy to remove through the resectoscope sheath, especially if it is less than 3 centimeters. What would be the ideal indications? A single small tumor with a short stalk and a front-end growth would be ideal indication. And if it is present within 2 centimeters of the ureteric orifice, here it is easier for me to get under the tumor, see the bladder wall beyond the tumor. So en-bloc resection here would become much easier for me. So let's look at a decision-making consideration. What are the various factors we would be looking at? What is the size of tumor, whether it is less than 3 or more than 3? Why 3 centimeters? Because this is a size which can easily come out through the sheath, the tumor being intact. How is the stalk? Whether the stalk is thin, broad base, or sessile. The thinner the stalk, it is easier for me to encircle a narrow stalk. How are the fronts? Thin, coalescent, or solid? A thin fronts tend to break when I try to do a en-bloc resection. So there is a risk of tissue loss. But if there are slightly thicker fronts or coalescent fronts, then the en-bloc resection becomes quite easy. Number, whether it is single or multiple, obviously single would be easier than multiple. And what is the size of site of tumor, whether it's a favorable or an unfavorable site. What do we mean by unfavorable size? Anti-wall, dome, lateral walls, near orifice, or very near the bladder neck, where turning there and getting under the tumor would be difficult. So if it's a small tumor with thin base, with thin or coalescent fronts, with single tumor and favorable site, this would be the ideal indication for en-bloc excision. But for larger, broad-based, solid tumors, multiple tumors, unfavorable sites can be done. but you would need some experience before taking them for en bloc excision. One of the biggest advantage of en bloc excision is that the quality of histopathology is very good. Just imagine histopathologist receiving the full tumor intact. So for him to analyze the detrusor muscle is easy. But if he receives a big chunk of resected tissue, even for him to find the detrusor tissue would become difficult. These are the various difficult sites. We have already discussed this. I'll show a few videos of them. So this probably is the ideal indication. A large tumor with a thin stalk. All I need to do is go under the tumor. So I will be going from 6 o'clock towards 12 o'clock. If I'm looking from the bladder neck, my watch is looking from bladder neck towards the anterior wall. Because this looks like a non-invasive tumor, I have taken around 2-3 millimeter margin around the tumor. You may find one blood vessel there which is easy to coagulate with laser, and then just separating this becomes very easy. Even such large tumors may come out in less than few minutes. The biggest advantage of laser here is the simultaneous hemostatic properties. So the procedure tends to be quite, say, clear vision and smooth, clear urine at the end of the procedure. But not all tumors would be so friendly. If there are multiple tumors, always start with the main tumor first. If possible, start on the floor and then move up the wall. Why? Because if I resect the anterior wall tumor first and then go to the floor, there may be some diffuse bleeding from the roof, which may hamper my resection at the floor. And if there are multiple small superficial lesions, they could just be fulgurated. You remove one major tumor bulk and smaller ones can be fulgurated. Now this is a posterior wall tumor. So this tumor is facing towards me. For me to get under this tumor is going to be very difficult. So instead, I am now unable to go from 6 o'clock to 12 o'clock. So I come from 3 and 9 o'clock and gradually reduce the size of the stalk from both the sides. So here we are coming from 9 o'clock and moving towards 3 o'clock. And after some time, we would come from that side. Now you can see the detrusor muscle is very clearly visible when you are using laser here. So gradually keep on undermining the tumor from both the sides. If at some place you lose the plane, then you could resect whatever is possible. Some small remaining tissue can be ablated at the end of the procedure. Now, if you realize, we have changed the orientation of the resectoscope. I have rotated my camera in a way that now my laser fiber is coming in the angle in which I want it to work. So proper use of angles and proper rotation of your telescope will make this procedure easier. So here some tissue was remaining behind, so I've ablated it by holmium laser, and that's the tumor hanging by a small strand which can be excised, and now the tumor is ready to come out. And all throughout again we can see good detrusor muscle in the floor of the tumor. Lateral wall, as we have discussed in TURBT, is difficult because of the risk of obturator nerve reflux. Again, here we would start at 12 o'clock and come towards 6 o'clock. So from above down will come. So you would come from above down or below up, narrow the stalk, and then excise the stalk. This is just a video showing obturator nerve reflux that can happen whenever you use electrocautery. The chance will be maybe marginally lower with bipolar, would not happen with laser. Obturator nerve block is the only way of reducing that. There are many non-holmium laser options for en bloc excision. Dr. Jason Ahmed is a very innovative urologist from Manipal University, and he has devised this cystoscopy scissor, which has electrocautery attached to it, which can be used to get under the tumor and excise small tumors. And here we can see thulium fiber laser being used. The disadvantage of thulium fiber laser is that it causes a lot of charring, and tissue identification may not be as good as with holmium laser. How do they compare? Initial study comparing 40 en bloc with 50 TURBT, they had comparable characteristics. Overall, en bloc was safer, effective. The recurrence rate at the end of 18-month follow-up between the two groups was similar. So they saw that recurrence is easy. It is at least as good as TURBT. The detrusor muscle was identified in 100% patients with en bloc, but only around 70% when piecemeal resection was done. So the current evidence says that it has an advantage of providing good detrusor muscle specimen. All energy sources can be used. It has been it has not been analyzed whether this would reduce the chance need for a second resection. We do not conclusively know whether it impacts recurrence. This was our publication in 2020, where we had published our first 67 patients, where we had done en bloc resection. This was the first report from India about this procedure. Lee et al. Did this systematic review in 2022, where they showed advantage of en bloc resection. They found that recurrence rate was similar, but by another Dr. Lee, a much larger systematic review with where patients were properly stratified, and nearly 6,000 patients were analyzed here, which showed that there is a significantly lower recurrence compared to conventional TURBT at 1 year, nearly 44% lesser chance. This is there irrespective of the type of the energy source used. This remains maintained at 2 years, but at 3 years, it is the recurrence rate is same. So by doing en bloc, we would be reducing the possibility of early recurrence. Uh, Delayed recurrence is probably a part of the disease process. Progression was not hampered. This did not reach statistical significance, but there was a numerical advantage in reduced progression. Detrusor muscle was found in significantly higher chance when en bloc resection was done. Muscularis mucosa was found higher when en bloc resection was done. Residual tumor was low. This was looked at by finding the tumor on repeat scopy that is done at 1 month. This was irrespective of the tumor size. The risk of bladder perforation was much less. Obturator reflux was much less. Catheter duration was low. Transfusion requirement was low. The resection time was higher because here en bloc resection takes marginally longer time as compared to TURBT. There was no difference as far as irrigation strictures, total operative time, and the need for irrigation. Definite oncological advantage because reduced tumor dissemination and potentially lowering recurrence, and improved complete resection, and hence probably postoperative chemotherapy could be better given in these patients. I would want to end by showing that the interest in en bloc resection is really rising. And now we have multiple robots which are being tried to help us with en bloc resection. So here, like say single port robot, through your resectoscope sheath, three equipment would go. One would carry a laser fiber, and one would be used just to hold the tumor and move the tumor apart so that you can properly get under the tumor and excise the tumor. So that shows the future of en bloc resection. This is being considered as a part of guideline, and I would end by saying that if you have the facility and once you gain the experience, this should be a natural progression for prostatic enucleation, and surely we should switch to en bloc enucleation. Thank you.
Thank you very much, Dr. Pankaj Maheshwari. It was wonderful. I've learned quite a few points. My presentation will have repetition of. Okay, there's a question from Nematullah. Is there any risk of tumor seeding in doing simultaneous TURBT and TURP?
So this was a scare or a fear which was there that probably if you do TURP and TURBT simultaneously, there could be a implantation in the prostatic fossa. But the literature doesn't support it. Wherever indicated, both can safely be done together.
Great. Okay. Let me share my screen. And so I'm going to, my talk is going to have a bit of a repetition of what Dr. Maheshwari has very nicely described, some very important technical points. And I would request all of you who have an interest in bladder cancer and who do TURBTs to have a look at his presentation again and try and grasp these important technical points. Some of these things is something that you learn over a period of time by continue to do so, and with his vast experience I think these are very important technical points that you need to. So I'm going to talk about a little bit about the difficult TURBTs or difficult situation which makes TURBT. So as mentioned already, and I've said that my talk is going to have a bit of a repetition, so I'll go through some of these things rather quickly. It's mentioned large and multiple tumors makes resection very difficult, and there is no harm in staging your rather than trying to be heroic, removing all tumor. Sometimes you end up giving complications rather than any benefit to the patient. The challenging locations, anterior wall tumor, and particularly those which are closer to the bladder neck, and they are really very difficult to see because of the location. And 70-degree scopes which are not there in endourological armamentarium anymore. However, flexible cystoscopy at the end of the procedure with the J maneuver can locate these tumors. So if you have any doubts, you should definitely do that. Tumor at the bladder neck, and particularly with the larger prostate, particularly with the median lobe protruding into the bladder, is a situation where you would have difficulty in identifying these tumors, and tumors close to the urethral orifice. Tumors which are there in small capacity bladder, they are unable to distend, particularly those which have had previous surgical resections or any other pathology, is again a challenging situation, and all of us have faced them one way or the other. Obviously, you require a 24-26 French resectoscope. People who have strictures, you would really have difficulty in advancing those scopes. So you need to really decide beforehand how will you deal with that situation. Now, in particularly larger tumors, there is a risk of loss of vision. And this is something that you do see, something which has reduced significantly with the arm block resection, because you are devascularizing the tumor beforehand. So the bleeding chances are a little bit. So as mentioned, that arm block resection is not possible in every case, particularly with large volume of tumors. There are various ways of controlling this bleeding. You need to first check the irrigation. Is the irrigation running? And that's very commonly happens in our part, that the nurse has gone, the runner has gone somewhere else, and there is an empty bag hanging with only air going through. So first make sure that the irrigation is, feel the hypogastrium. Your bladder may be full, and that's why the irrigation is not going through. And this is something that you see very frequently in TURP and also in TURBT, that full bladder would not allow the irrigation to pass through. Inflow and outflow are should both be functional, because otherwise your vision would be affected. Check the blood pressure. Sometimes the anesthetist doesn't want to bother you, but always peep over the curtain and see if the patient is really in a systolic hypertension state, which makes bleeding, particularly from prostate, but also from bladder tumors. So if your vision is poor, after you make sure of all these things, you have to do the iliac evacuation so that you get rid of all the clots, so that your vision becomes better before you start fulgurating these tumor, and then identify those areas which are bleeding actively and take care of these bleeding. This is something that the younger urologists probably would not know, but this is what we used to do, called the Helmstein's maneuver, in which you need to inflate a balloon in the bladder, which is typically a sterilized medical grade condom, which you put on the top of your cystoscope, and you inflate it with your irrigation fluid, and it provides a tamponade. And if you do this for 5 minutes, you probably will go in again and you will find that these bleedings have stopped. This is something that you do in open surgery all the time, that you put a swab, look around somewhere else, and then come back and take care of these bills. But this is something that is not very frequently done. Now, if you have perforation, and particularly if you have perforation in the very initial part of your resection, it makes the whole procedure very difficult. You continue doing it and use alic evacuator. Even near perforations will become full perforations, and if they become perforation going through the into the peritoneum, particularly with a full bladder, that's always a possibility. In that situation, there would be significant extravasation of fluid with a lot of viable cancer cells, and theoretically, it has a significant risk of seeding. The obturator nerve, Dr. Maheshwari has talked about it, and we're going to just quickly touch upon the obturator reflex. And before we do that, these are the lateral wall tumors, and this is particularly notorious for obturator reflex. So you have larger tumor on the lateral wall. I find use of laser in that situation a little more difficult. Laser has a very thin probe, 500 micron or 365 micron fiber that you're using. It is difficult to handle. It just moves around significantly. You have to put an open-ended catheter or something to stabilize your laser fiber so that you can hit appropriately. Make a decision whether you want to do a staged or a single step procedure. If it is something that is safer for the patient, do stage your procedures. So it's important that we should be aware of this obturator nerve, which is passing on the lateral or a pelvic side wall, something that you see on cystectomy. And direct electric current stimulation results in a jerky movement of the leg, which can cause problems not only to the surgeon, but also to the patient, and can also cause perforation. You need to decrease the distension of the bladder, make sure that your patient is nicely padded, and all these things are important maneuvers. Obviously, the type of anesthesia, well, I personally see that all the journal is recommended in such situation, but it doesn't make a huge difference. If it has to happen, it will happen. Obturator nerve block is something which is not very frequently practiced, and I have sat down with our anesthetist, and in fact, they were able to help us with the nerve blocks because they're not very used to doing it. And it's a pretty straightforward procedure, which can be done at the beginning of surgery before you start off your obturator nerve is passing from the obturator foramen. And if you move from pubic tubercle 2 centimeters lateral and 2 centimeters down and go towards the obturator foramen, this is where the obturator nerve is. And you can very well anesthetize that nerve. You can use an electric stimulator and pass that. And once you start seeing this kind of movement with electric stimulation, you will be able to locate that nerve, and then moving a little superficial, you can inject your local anesthetic. And then when you use electric stimulation, you will find that these jerky movements are no longer there. And that's the time that you can position your patient and start off a procedure. So obturator nerve, particularly for larger tumors, obturator nerve block can reduce the obturator reflex. Now, about the urethral orifice, and I've seen people are really afraid of tumor around the urethral orifice. The problem is that if you do not do a good resection, there is a very high likelihood of recurrence. Beware that tumors in that location in the trigon have a significantly higher risk of upper tract involvement. So at some point in time today or later on, you need to make sure that you have seen your upper tract and try and exclude an upper tract urothelial cancer. The surgical challenges of periurethral orifice tumor is that it can damage the muscle structure, which can cause reflux, which is not a very significant problem at this age. So you can be a bit liberal while doing the resection of the tumor in that location. You have to be careful but just to save the urethral orifice, you should not leave the tumor behind. And as I've mentioned by Dr. Maheshwari, urethral stenting should preferably not be done unless you have a significant fear that you obstructed the urethral orifice. Often it is not visible after the procedure. So this is one of the tumor that we have seen. And I find that although the size may not be appropriate, but the control that you have with arm block resection, particularly for tumors which are close to the urethral orifice, is much easier than if you do piecemeal resection. So this tumor was very close to the urethral orifice, and we have resecting it. In fact, it's end up being a piecemeal because there were a couple of tumors close to each other, and we have removed these tumors. So it is arm block, but not purely arm block resection. But the whole idea of doing it is that you can save the urethral orifice because my control is better. I can see the urethral orifice when I'm resecting because I'm moving away from myself during the arm block type of resection. And in this case, we're using electrocautery with a loop. You can use a lot of things, including laser, including the Collins knife or the loop, whatever is feasible. It can all be done with the very similar result. Obviously, the advantage of laser is that your hemostasis is much better in that situation. At the end of this resection, I'll try and show the urethral orifice, which is very close and which has been saved by this procedure. So even if you don't see it or you have done a bit of a resection of the urethral orifice, typically does not have any significant long-term consequences. So it does not really matter. So all that multiple tumors close in the trigonal area have been resected. And in the end, we were able to see the urethral orifice nicely without any significant involvement. So that's the urethral orifice which was there. And you can see the detrusor muscle as pointed out. And we have also published our result and 100% detrusor muscles in all arm block resection specimens. The important thing to remember that if you are doing, the next cystoscopy showed that there is a bit of a golf hole type of urethral orifice post resection, which is not a major issue in this age. Important thing is that you should not use blending current. And as mentioned, the coagulation should be avoided in this area. And this is only possible if you are doing arm block resection rather than the piecemeal resection. This is another large tumor. Again, I've tried to do arm block resection only because it was close to the urethra. And this time I'm using the Collins knife. You can see there are multiple tumors sitting on top of each other. Really difficult to identify the stalk of every single tumor, but going all around, I'm able to remove these tumors with a clear margin and also being able to save the urethral orifice. As mentioned, it is not possible to move any systematic fashion, and particularly if it is away. This is the urethral orifice, you can see, and it is quite safe here. Now, another important problem that we face is bladder cancer in diverticulum. We know that they're not very common, but you do often see them once every 2-3 months. They have a higher potential for invasion and metastases because there is a very scanty muscle in the secondary diverticulum. Obviously, they are secondary to obstruction. And TURBT often fails to remove completely all the tumor, but that's not an issue. So don't be worried about that. We'll tell you what to do in a situation like this. You can take a few biopsies and then and then coagulate the rest of the tumor. Don't try to remove every bit of a tumor because this would cause perforation of the diverticulum. So this is a wide neck diverticulum, and you can see that this tumor is clearly visible coming out from the diverticulum. And in this situation, you can easily take few biopsies. Sometimes the neck of the diverticulum is very thin, small, and this is a particular risk. So my first step in a situation like this is to make the neck of the diverticulum wide. And the reason is that I'll be able to go inside and remove tumor very carefully. And the second important thing is that when you use intravesical chemo or immunotherapy, there is a greater likelihood that your intravesical agents would be able to go inside these. So once you have these small neck, you can make them wider. You'll be able to see inside the diverticulum, and you'll be able to resect them. Now, the anterior wall tumors, as mentioned earlier, 70-degree scopes is able to see them, but we don't have it. We used to have it, but it's no longer functional. Flexible cystoscopy, doing a J maneuver, would probably be able to identify. And then your assistant can apply some pressure from the hypogastrium, try and make this tumor more accessible to you when you're doing the resection. Now, the other problems with bladder cancer and TURBT is that sometimes you have significant lymphovascular invasion, and these tumors do poorly irrespective of how good a procedure you do. Variant histology, again, these are the tumors which are more likely to respond to cystectomy as soon as possible rather than just TURBT and intravesical, although your pathology may show non-muscle invasive. And carcinoma in situ, again, difficult to identify. I don't have an access to blue light cystoscopy. But blue light cystoscopy has a certain advantage in this situation. And if it is available to you, please do use in such situation. Now, other problem that we face, because we know that the bladder cancer is a disease of aging people. You may have poor anesthetic risk in these patients, and sometimes it is not possible to even give regional anesthesia for. So that should not stop you. You can use some form of a gel to numb the urethra, and you can put 2% or 4% lidocaine through a catheter into the bladder, wait for 5 to 10 minutes, and that would provide you enough anesthesia that you'll be able to take some representative specimen and send them to pathologist for evaluation. If you have EMD, and EMD is very helpful in giving a greater penetration, not only of mitomycin C, but also of local anesthetic. So it basically make the bladder wall more amenable to ion perfusion exchange, and that allows for local anesthetic to have an effect, and you will be able to do a procedure with laser and a flexible scope or even a rigid scope, and then take representative specimens. As mentioned, that pathologist would give you as good an outcome as your TURBT is. So if you provide them with a specimen without diathermy artifacts, they will give you the appropriate input. And if they have missed a high-grade tumor because it was affected by your diathermy, then it would be very difficult to make the right decision on the right time. Now, there are some post-operative challenges which are there, like clot retention. Delayed bleeding can also occur because sometimes your scab or the diathermized area dislodge because of high intra-abdominal pressure, constipation, activity, or whatever. And in this situation, bleeding can occur even after 2 weeks of surgery. Some people have significant dysuria and difficulty in passing urine post-operatively, and they should be dealt appropriately. So these are some of the challenges, and I think between myself and Dr. Pankaj, we have tried to provide you with some tips, and it would be good if we can have some questions, some observations before we move on to Dr. Abdul Hafeez's presentation on check cystoscopy. So any question, any comments so far? Let me see if we have. Okay, kindly explain some management from your experience regarding perforation. Okay, so if there is a perforation during TURBT, it's important to see what is the site of your perforation. If your site of perforation is on the dome or anterior wall, then it would be a significant risk of bladder, the dissemination of the cancer cells. Although it's a more of a theoretical risk, but definitely there is a possibility. So you need to identify that early on and put a catheter. Don't put a suprapubic catheter. Just put a good 3-way 22 Sharia catheter and have gentle irrigation, and make sure that you see these patients frequently in the post-operative time to make sure that the inflow outflow is proportional, because if your inflow is high and it is going out of the bladder, it will make this perforation big. Okay.
Can I add something here, sir?
Yes, absolutely, Dr. Pankaj.
So the risk in bladder perforation, apart from fluid and tissue dissemination, is often there could be bleeding by the side where there is perforation. So once you land into perforation, the first thing would be to do a point coagulation and get control of bleeding. Remove whatever tissue you can. If you have lot of tumor remaining to be removed, then probably better to stage it. If it is something small remaining which can be completed, then you could complete it. But hemostasis, removal of tissue, good drainage, and staging. These would be the four important things. Remember, microperforations are very common. There are studies which say that if you do a cystogram at the end of TURBT, the possibility of finding extravasation may be as high as 50%. But we are not worried about that. Even intraperitoneal perforations, all intraperitoneal perforations would not need exploration. Small intraperitoneal perforations may settle well with a catheter. But if it's a large intraperitoneal perforation, then probably exploration may be needed. So these are just few thoughts I thought I'll add.
Perfect. Yes, I agree. So antiplatelet drugs is not a problem. I do not stop antiplatelet drug, particularly in these elderly patients who have history of some thromboembolic event in the past, be it cardiovascular or neurological. In that situation, they can continue with the antiplatelet drug, but some of the new generation strong anticoagulants, something that you probably be best avoid them. If it is not possible, then definitely use laser rather than bipolar or monopolar electrocoagulation. Yeah, so laser is the key in that situation. Okay, so any further questions? Fine. So how can we know that perforation is small or large? Well, if it is a large perforation, it will start to shout, and you're anesthetist, and your own hand on the anterior abdominal wall. I have this habit, and I think you should all have that keep putting your hand every now and then on the tummy, and particularly before starting a procedure, get an idea of how turgid the bladder is, what is the consistency that you're feeling, and keep doing it throughout the course, even with and this is something that we have learned from not using the continuous flow resectoscope in the earlier years of our life. And now we have continuous flow resectoscope, but still this habit is good, that you keep feeling the anterior abdominal wall, particularly the hypogastric area. But if it's a large perforation, keep patient in very active surveillance. You probably may need to put ultrasound guided drains. At times, majority of these patients would not require any intervention like a laparotomy or something to repair, and they would all heal nicely in 3 to 4 weeks time. And if you're reasonably sure, do a cystogram before you remove the catheters. Well, systemic chemo after a perforation of a high-grade bladder cancer. And I have had a very detailed discussion with some of the leading urologists, a friend of mine who is a world authority in GU cancer, Professor Anwar Hussain. And he says that there is no real indication, there is no data that systemic chemotherapy would be of any advantage if you have a bladder perforation. But keep your patients in active surveillance, and it would be a good idea to do some cross-sectional imaging about 6-8 weeks after the procedure to make sure that everything is fine before you start any treatment. So can Zika be given in mild hematuria or should? So the real question that you need to ask, can you stop the irrigation for 30-40 minutes? If you can, then I think you should give. Obviously, if you have a large tumor which is clearly sessile, multiple, looks like high grade, there is no advantage of giving intravesical chemo post-operative. So it is best indicated for TA low-grade cancer, in which you would not require anything else besides TURBT and mitomycin. Pankaj, any observations, any comments on this question?
No, I think nothing more to add.
Okay, great. Hafeez, you're next.
Thank you very much by the Professor Hammad Ather, and also I'm very much thankful that they have given me the chance to discuss with this most important topic in a bladder tumor, that's the CYSTOSCOPY. So at the end of my presentation, you will be able to understand that what are the indication of cyclostoscopy, what are the new modalities for the imaging of the bladder cancer, and what are the recent advances in the follow-up of the non-muscle bladder cancer. So I would be much more concerned about this portion of the bladder tumor, which is a non-muscle bladder cancer. So we know that the bladder cancer is one of the progressive disease, and that can start from the urothelium, which is superficial, till it get enter into the muscle invasive, and then it spread to the distant organs. So we know that this is one of the proposed follow-up schedule for the patient who have the non-muscle bladder cancer, and we know about the low, intermediate, and very high risk patients, and they have the proposed schedule for the follow-up cystoscopy. So this is the one of the recent modality in the photodynamic diagnosis, which is a blue light cystoscopy, in which what we do around 30 minutes or 1 hour before doing the cystoscopy, we put the patient this 5-aminolevulinic acid or hexoaminolevulinic acid in the bladder, and for about 30 minutes, and then we shift the patient to the OR, and we do the specialized the call store system, which have the specialized lens and with the blue light. So that can be used in a patients who have the positive cytology but have the negative white light cystoscopy, patient with initial with the CIS multifocal tumors, and obviously it is contraindicated in a patients who have the BCG done within 90 days, patient who have the gross hematuria, patient who are known sensitive with the 5-aminolevulinic acid, and patient with known porphyria. So this is one of the recently published BJUI article regarding the blue light cystoscopy. It's one of the meta-analysis that who look the primary outcome to look the flexible blue light cystoscopy versus the white light cystoscopy, detecting the bladder cancer recurrence in a patients who have suspicious blood lesions. So the surveillance for the NMIBC with the flexible blue light cystoscopy could detect more suspicious lesion as compared with the flexible white light cystoscopy, with increased rate of false positive sometimes that can lead to the overtreatment. So the most appropriate candidates for this surveillance are the flexible blue light cystoscopy, the patient who with a high risk of non-muscular bladder cancer, and especially with the CIS. So overtreatment which may be acceptable for the patient for those. This is the one of the video which I want to show you, that this is the specialized, as I told you, with the call store system, which have the white light with the blue light cystoscopy. The certain lesions which are not so visible on the blue light cystoscopy, and if we do turn on the blue light, and that these lesions you can see here, the lesions can appear more enhanced, because these tumor cells have a capability to take the more this the 5-aminolevulinic acid that are taken up by the tumor cells, and that get enhanced by doing the blue light cystoscopy. So if we looked at and by this we can do even the blue light TURBT as well. So by doing this TURBT, by using this blue light, can improve the resection rate, and as well as it will prevent the recurrence of the bladder tumor. So this is the video which you can see here. This is the enhancing lesions can be seen. So coming to the second thing, which is the narrowband imaging cystoscopy, and in which that can be done in a flexible cystoscopy, does not need a dye, and it has basically the principle look that these thin capillaries over the bladder mucosa, they are taken up by the blue lights, which have this 415 nanometer, which is the wavelength, and that can lead to the brownish appearance of these thick blood vessels. So this is the one of the article that has basically a randomized control trial between these narrowband imaging cystoscopy with the white light cystoscopy in a multi-center study. So the two experienced surgeons, they were responsible. One was doing for the NBI, another was doing for the white light cystoscopy. So they looked the specificity, sensitivity, and false positive rates for NBI and white light cystoscopy. So they looked at the NBI, if you compare with this white light, have the 97.7% sensitive, and if you look at the specificity, it's 50% as compared to the 25%. So the result of NBI, which is narrowband imaging, have high sensitivity and a superior early bladder tumor and carcinoma in situ detection as compared to the white light cystoscopy. This is the recently published article 2021, and this is the one of the systemic review and the meta-analysis that we compared. They looked bad basically with the narrowband imaging and photodynamic diagnosis, which compared the white light cystoscopy. So this is 17 prospective randomized, non-randomized, and randomized control trial were included, and they demonstrate there is a tumor resection with either photodynamic or NBI as with lower recurrence rate as compared with the white light, and have the greater diagnostic sensitivity. So this is the one of the video which I want to show you with the narrowband imaging, that this can lead to the more visualization. So this enhanced surface it basically enhances the vascularity. You can see this is the blue lines, which is basically not a blue, it's a cyanide appearance, and this is the tumor cells get more enhanced. And by doing this, using this NBI, you can do the bipolar vaporization, we can do the TURBT as well. So because it will enhance the visualization of the tumor. So by basically it's only depend upon the wavelengths, so which are absorbed by. So and another the positive point that we can do that by using this NBI, the nephroscopy from below, we can do flexible the ureteroscope and can enter into the kidney and can see the papilla as well. So the small lesions can be detected inside the kidney as well. So that it has the benefit that can be visualized much more. So, and the third one is the image S, which the family knows as SPICE, Stores Professional Imaging Non-System, and the Journal of Endourology published in 2021 that enhanced endoscopy with the image S1 chroma improves the detection of the non-muscle invasive bladder cancer. So the chroma improves the detection as I told you about. This is the one of the new modality and can be done in both setting low grade and the high grade disease. So the cystoscope with the chroma contrast enhance facilitate the detection of the bladder tumor that are not readily appreciated with the conventional white light cystoscopy. So these you can compare on the right side. And this is the cystoscopy using the SPICE. On the right side, you can see here there is the red lines over the tumor. They get much more thicker, and there's much more fluctuation or demarcation, sharp demarcation. Once you do this technique, and it will much more SPICE, and that can basically gives about that the tumor detection is much more on that area. So this is another article which is published that evaluate the spectra and spectra B mode in a chroma system, that in which around more than 3,700 images of these spectra and B mode, they were sent to the urologist, which were member of Urology Society of India, and they were observed or asked about that either they found that this cancer is yes, no, or they cannot say anything about it. So 273 observers participated, and they found that the white light spectra and B, they were found that they have 89, 91 and 88% respectively. So these basically in patients with the cancer with the spectra and we improve the diagnostic accuracy over the white light cystoscopy. So on the right side you can see the images with the spectra mode, the tumors get much more enhanced. On the right side, where the left side images, this is a conventional white light cystoscopy. So this is what the guidelines say about it, that the photodynamic diagnosis has been shown improved detection of the bladder cancer, especially CIS, strong, it's level 1 evidence, while take the multiple biopsies or perform the photodynamic diagnosis when you have a normal looking urothelium with the positive cytology. Another new thing which is recently the people are doing in their many centers all around the world, that's Holmberg laser as an office-based cystoscopy. So around 109 patients, they were evaluated, basically included in this patient study, who have the superficial recurrent bladder tumors, and they were treated with the Holmberg laser with an OPD basis, and by using this flexible cystoscope with under local anesthesia. So they found that treatment of small bladder lesions with the photocoagulation with the Holmberg laser is a well-tolerated technique and offer acceptable level of cancer control with a lower cost. So this is a recently published BJU article in 2024, the long-term outcome of and cost effectiveness of this office-based cystoscopy in papillary low-grade lesions. So they looked this office-based cystoscopy under the local anesthesia. So they found that around 270 patients with recurrent TA low-grade lesions, they underwent office fulguration, which is Holmberg laser, and 10-year incidence of cancer-specific mortality and progression were only 0 and 3.1% respectively. So there's a cost saving, which is around 7,000 Canadian dollars per patient. So the cost is also cost acceptable, quality of life is better. So this is one of the small lesions with the follow-up. The patient reported outcomes of the laser ablation with the bladder tumors. It's a prospective study, and it's a new method as we discuss about the transurethral laser ablation and under local anesthesia. So the patient were given the questionnaire, and they were asked about the urinary symptoms post TULA, which is transurethral laser ablation, post operative side effects, quality of life, day 1 and 14. So what they found, that the primary the bladder tumors, TURBT remains the gold standard as we know, but the small lesions with the recurrent lesions with known pathology, so they can undergo for the TULA. So also we can do this in a patients who are the frail patients, they do not tolerate the general anesthesia. So what's the take-home message? That the bladder cancer surveillance cystoscopy remains the gold standard for the diagnosis, follow-up, detection and recurrence after TURBT. The recent optical advancement improve the tumor visualization like NBI and photodynamic diagnosis, improve the diagnostic accuracy as compared to the conventional white-eyed cystoscopy. Office cystoscopy fulguration is increasingly used for small, low-grade, recurrent, elderly comorbid patients who cannot tolerate the anesthesia, suitable for the small lesions. If you are to the future direction, that enhanced imaging combined with risk-adapted outpatient management is shifting bladder cancer surveillance towards a more precise, patient-friendly, and cost-effective approach. Thank you so much. Thank you so much for your patience, and thank you.
So let's conclude today and talk about if there are any further questions, any other issues that you would like to discuss. But I would strongly suggest that what we have discussed today by both Dr. Maheshwari and Dr. Hafeez Qureshi's presentation, some very important technical tips and tricks which are extremely vital to understand whenever you are dealing with bladder cancer. So if there are no further questions, I would request, there is a question by Kamran regarding anterior wall growth resection, what mechanism or technique can be? So as is described by Dr. Maheshwari and myself, is that the best thing is that you first of all assess how big and where is the tumor, for which if your rigid cystoscopy or resectoscope is unable to locate, you put a flexible cystoscope, do a J maneuver and look on the anterior wall, particularly close to the bladder neck. That's one of the most difficult area to access. But with flexible scope there, it's very, and you can use laser if still you're unable to see it with your rigid scope, and try and fulgurate that area, because you must have already taken quite a few specimens. Pankaj, any further points about this anterior wall tumors?
No, sir. I think there are some long length resectoscopes available which will help you reach anterior wall, or a proper compression and optimum filling of the bladder. A combination of all these three will help you reach anterior wall and resect those tumors.
This one last question by Khuzaima Anwar about high-grade diverticular cancer. Now, high-grade diverticular cancer should all be considered as more or less muscle-invasive disease. There is no muscle there, so consider it for early cystectomy. I'm not a big fan of partial cystectomy, but there's probably one indication of bladder preservation and removing the involved. But make sure that you have taken some random biopsies. That's another indication for random biopsies. And also do close surveillance with cytology and cystoscopies because it's really a field change disease and it can recur any other point. So if you're doing partial cystectomy, that's not the end of the story. It's actually beginning of a story. Okay, so thank you very much. And I'm really grateful to Dr. Pankaj and Dr. Hafeez Qureshi for their presentations and important tips and tricks from their experience. We would conclude today's session, and next Saturday, we will be talking about the radical nephroureterectomy, the cuff issue, and also lymphadenectomy during radical nephroureterectomy. Hope to see you all next Saturday. Thank you very much and have a very good evening.
Thank you.
Thank you. Thank you, sir.
Good night.